Philadelphia International Medicine, PIM, provides international patients and physicians with access to an unmatched network of world-renowned doctors, surgeons, and hospitals that deliver personalized medical, surgical, and rehabilitative care ranked among the best in the world. Since 1999, Philadelphia International Medicine has helped patients and physicians from around the globe eliminate the guesswork, planning, and anxiety of finding and connecting with doctors and hospitals ranked among the best in the world. With 8 hospitals, 2 medical schools, 2 cancer centers, and hundreds of top doctors, only PIM can bring you into its medical family with one easy phone call or email. Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
I really like to bring you up to speed and remind myself about the recent advancements in the area of pancreatic cancer. There is a reason for us to be more optimistic in terms of this tumor type. It is still a major killer in the United States and across the globe. As you can see on this slide, the median age remains at around 70, but it's not unusual for us to see patients in their 30s and even 20s. There are several risk factors why this disease is on such a rise. It is related to smoking. There is a parallel epidemics of obesity that drives the dyslipidemia, and that also feeds into the risk of pancreatic cancer. It is rising on the background of chronic pancreatitis, and this is why pancreatic cancer is oftentimes associated or is preceded by several months, oftentimes by diabetes type 2. There are several genes that are linked to chronic inflammation in the pancreas, and therefore they induce chronic pancreatitis, which eventually leads to development of pancreatic cancer. And I have listed some of these genes here. This is they encode different proteases that pancreas normally secretes. But when these proteases are hyperactive, that induces chronic inflammation. Cystic fibrosis gene is known to induce inflammation, though its association with pancreatic cancer is less clear. Obviously, genetic cancer syndromes such as Lynch, VHL, Peutz-Jeghers syndrome, and obviously the hereditary breast ovarian cancer syndromes such as BRCA1, 2 mutations, PALB2, ATM mutations. So these are common familial genes, which we, and I'll show you in a few slides, how important it is for us nowadays to look for these gene mutations in those patients. And P16 mutation, the gene is named CDKN2A. This is typically is associated with melanomas, so moles. It can also be a risk factor for pancreatic cancer. So the way that things are at this point is that the recently updated SEER database, which is the government database of all the mortalities and outcomes in Medicare, Medicaid beneficiaries, is about 7.7% 5-year survival rate. Not very good. It moved up from 6% or 5% in the preceding years, but it's not, as you can see, it's not a major stride. This is what makes pancreatic cancer so worrisome to everyone, because it is projected that by year 2020 and beyond, it will be #2 killer in a cause of cancer death in the United States. And I'm pretty sure across the globe, the trend is very similar. There is a certain contribution, as I mentioned, of the nutrition, and there are different hypotheses, and my lab in particular is working on one of these hypotheses, that excessive metabolites, excessive calories, and lipids leads to development of this inflammatory condition called obesity and metabolic syndrome. So that affects pancreatic cells, self-renewal. It causes pancreatitis and inflammation, and that leads subsequently through mutational process to the development of pancreatic cancer. In the United States, 3 years ago, the NIH and the National Cancer Institute identified key priorities and issued the report where the science and the clinical research have to focus in order to solve this terrible illness. So the 4 initiatives that are put forth include understanding the biological relationship between pancreatic cancer incidence and nutrient excess. We are working diligently in development of new biomarkers for early detection, because everybody knows this is the key to increase the cure rates. We are focusing on development of new treatment and drugs that will interfere with the key oncogene, which is undruggable at this point, that is KRAS. There's also significant enthusiasm on immunotherapy and modifying the stroma. The pancreatic cancer is not one disease. It's a collection of diseases, not only genetically, which I'll speak in a few minutes, but it also is a collection of diseases based on how the patients present and what we can do for them. So pancreatic cancer, if you take 100 patients, about 20% of them will be potentially resectable and will be taken to surgery. 16 of them will get clear margin resection. It's by no means is cure, because the majority of them will have recurrence. And the reason for that is that pancreatic cancer, even at, we learned from the mouse models, even at pre-malignant stage, it sends these cells to the circulation. We can detect these cells literally in the blood, in the tube of blood. So the ability of these cells to migrate early on is what makes this cancer so difficult to cure with surgery. So it's it's a systemic disease from very early stages. So only 4 out of 100, now it's 7.7% are cured. The rest of them are either localized and unresectable, and typically, because the organ of pancreas is situated in a very busy intersection of major blood vessels and nerve pathways. So to resect this cancer is surgically very, very challenging. There is a whole profession in surgery to be a pancreatic cancer surgeon. It is very difficult, arduous path. These resections are technically very, very challenging, because you literally have to peel off the cancer nodule from adjacent major vessels. And this is what any millimeter more of advancement of this cancer towards the blood vessel makes it unresectable. That's why the prevalence of localized unresectable pancreatic cancer is so high, as high as 35%. And the rest of the patients are either already at the stage when they're dying, or have incurable metastatic disease. And like I said, the majority of patients will end up here. So 93%, as it stands of now, will be down to metastatic stage and die from it. These are the current standards, and I'm pretty sure all of you know this just better than I do, because this is what is the standard of care, and we practice it across the globe the same way. The study by Kunroy and co-authors introduced FOLFIRINOX. This is done in Europe, and this is the first study where we showed that the survival rate can approach 1-year timeline, much better than gemcitabine. And then this is the company's slide, and I took it for a reason. They have to have very specific graphic enhancements, like color and shading, show this little improvement of survival with introduction of Abraxane on top of gemcitabine. So the efficacy, as you can see, is actually lower than FOLFIRINOX, but this is much better tolerated regimen. And FOLFIRINOX is rough. It's we almost universally do dose reduction in comparison to what has been used in the original study. We always, almost universally, use growth factors to make sure the patients don't become septic. These are the two studies that sort of set the stage for the two regimens, and I can assure you that patients blow through these regimens fairly quickly because the disease acquires resistance and progression is documented. We're still not doing very well. So you can start with option A, go to option B, start with option B, go to option A. In some patients, we use two drug regimens, like a full Fox type, 5-FU and Oxaliplatin. It doesn't matter how you apply your fluorouracil. The effect of 5-fluorouracil is very minimal. There are two competing studies. This is a that showed competing information. The Conco 003 showed that if you add Oxaliplatin with a 5-FU, they call this regimen off for some reason. Anyways, it showed some survival advantage, like shown here, very small advantage, but real. And this Vogue study, which was just recently published in JCO, Journal of Clinical Oncology, that is, showed essentially no statistically significant advantage. So two-drug regimen are used in a setting where patients are too frail to tolerate a three-drug combination with FOLFIRINOX. But the benefit of adding Oxaliplatin to 5-FU, or the benefit of 5-FU alone, is very marginal. This is a more recent study called Napoli, published in Lancet. Here, I think the comparison, to be fair, is not really appropriate. You compare 5-fluorouracil to 5-fluorouracil with liposomal irinotecan. A lot of toxicity. There is a survival benefit. That's why the liposomal irinotecan is now granted a license in the United States. But I'm not sure how this would compare to FOLFIRINOX, given with dose reduction. For the reason that we are so unhappy about what the status quo is in pancreatic cancer, it prompted a group of investigators, including advocacy group Pancreat, who published this article in JAMA Oncology in May of this year. And basically, they say here that we put, in the last 10 years or so, we put 13,600 plus patients on clinical trials, and these patients contributed their lives, their health, to promote the research. Of those 13,000, 11,000 derived no benefit whatsoever, suggesting that the pace of advancement, if we keep doing it the same way, is going to be incredibly slow, unacceptably slow. So what they argue here is that instead of doing these megagalactic trials, which is really focused on innovative thinking and putting patients on a phase 1 program, so as a result of this sort of strategic realignment of pancreatic cancer clinical research, we are now really trying to understand the biology of the disease and put patients on clinical trials that are most relevant to the identifiable genetic alterations in their tumors. The lack of progress is not for the lack of trying. We did try. And this is the list of many drugs that we've tried in the past. I personally wrote with Steve Cohen a paper of Avastin and therapy. There are multiple trials where people tried TKIs, axitinib, or bevacizumab in combination with chemotherapy, failed. Disrupting stroma by blocking Sony Hedgehog with vismodegib failed. Actually, made cancer outcomes worse, more rapid metastatic progression. Hypoxia a drug that was everybody's hope, ivofosfamide. This is the drug that gets activated by hypoxia. Failed. Immune response.
I just want to remind everybody, we're getting an awful lot of feedback. If you could please, once again, mute your microphones. If you've joined later, you may not have heard that. Please mute your microphones.
Wait, please don't touch it, because it makes a lot of noise. I'll have to scream, otherwise I'll lose my voice for the rest of my killing day today. So immune response modulation, vaccines. Again, so far no success, but there is a clear and enthusiasm from
Away across to me. Yeah. Do you know how to? Yes. Well. Okay, that doesn't do it.
We try to mute one of the microphones.
It also might help them to improve. But no one's on other than me.
Alfredo, I think your microphone is making noise.
Yeah, no, there's a location. There he goes.
All right, so we'll continue. So we talked about the vaccination. Again, a lot of enthusiasm in research groups on the East Coast. I know of significant efforts in Johns Hopkins group and from University of Pennsylvania. So far, no breakthrough. We tried CAR T cells to mesothelin. We tried various ways of vaccinate patients to mesothelin using mesothelin vaccines. So far, no clear signal of activity. We try to block stem cells, so you're blocking notch signaling with this antibody. Again, no success. On the EGFR strategies using erlotinib, again, very borderline activity, only 2 weeks of survival improvement at the cost of high diarrhea rates and skin rash. There was an attempt to suppress inflammation with ruxolitinib, which is the JAK inhibitor. Again, no success. The trial was folded. But it's ongoing, and there are still good ideas out there that are currently being tested in clinical trials. There is another approach to disrupt the stroma with a drug called hyaluronidase to loosen up the intercellular matrix so that the drugs can better penetrate the tumor. This study is ongoing. There was relatively good evidence that if you apply high-dose vitamin D, it will reprogram the stroma in the tumor microenvironment and normalize it, make it less supportive of the cancer growth. But this is also ongoing. Okay, so we now have a quiet environment, noise-wise. There's ongoing research, and a group of University of Minnesota and TGen now are studying this drug called Minilite, which is a derivative of a Chinese herbal traditional medicine called tripolite. Now this study has passed phase 1, going to phase 2 testing. And here with our institution, in many other places, we testing concepts where we would inhibit Wnt pathway signaling with 2 drugs currently the lead products of, in this area, Vintictumab antibody and Ipafricept, which is a scavenger of Wnt WNT ligands. So this is the slide that I borrowed from Hingarani's group publication in cancer cell 4 years ago. Basically, they used this pegylated formulation of hyaluronidase, an enzyme that destroys hyaluronic acid in the tissue microenvironment of pancreatic cancer. And in mice or in humans, pancreatic cancer is a very dense, rubbery. You can drop it and it will jump away from you. This is how thick the interstitial matrix is. So hyaluronic acid, which is highlighted here with the red is the cells. The green colored hue is the actual hyaluronic acid. With the use of hyaluronidase, which destroys it, it softens the matrix of the tumor and makes it more penetrable for the chemotherapy. So the clinical trial now is in phase 2, is ongoing. There is a so the endpoint of this study is progression-free survival. The goal is to get 260 patients. When we talk about clinical trials, this is the type of idea I try to pass across the table to the patient. That when you talk about clinical trials, it's really not. It's a combination of commercial interest from the drug company that is trying to put their drug on the market. There are millions of dollars at stake for them, and there is a research question. However, whether you like it or not, but it's not really the way to help you. We use clinical trials in the situations when it is most appropriate, but it is something that you have to be aware that this is not designed to take care of you as a person. The other thing is, in across the world, and the world is now catching up, the clinical trials for metastatic cancer, and this is where pancreatic cancer is still lagging behind multiple trials, many more trials in breast cancer, although this is now becoming the second potential cause of cancer death. We're still behind lung cancer, and we're catching up with colon. The sad truth about any metastatic cancer situation is that everybody wants untreated patients. Once you get through your first line of chemotherapy and progress, the number of clinical trials drops precipitously. This is a recently updated result of my own search on clinicaltrials.gov. This is the international worldwide registry of any clinical trials. So go to clinicaltrials.gov, find out yourself, but you'll see that there is roughly 1/5 of the trials that are available for patients who had the one line of prior chemotherapy, and there's literally no trials for the third line in pancreas cancer, which is terrible. What do we know about pancreatic cancer biology? I like to reference you to this article. It was published in Nature in 2016. Almost universal, and you can see it here. Sorry for the small font, but you can see here that across the board, P53 is universally mutated. There is another obvious key driver of pancreas cancer, which is KRAS, but you will notice that there are some white spots across this panel, and the reason for that is there is about 10% of pancreatic cancers that are KRAS wild type, not because we cannot detect it, but it is because some of these tumors choose other oncogenic drivers, for which we have a better possibility of using drugs. The community is now shifting to classify pancreatic cancer to several buckets using different genetic markers. There is a clear interest to identify early those cancer patients who have genomic instability. These are usually carrying mutations in BRCA1 and BRCA2 genes. Not all pancreatic cancers that are BRCA1, 2 mutated will have genomic instability. The reason for that is that for the cancer to become genomically unstable, it has to deactivate the second allele. We have 2 copies of chromosome. One is mutated, usually inherited, because if you have 2 mutated, human body cannot develop. But if you have heterozygous mutation, and you get a cancer, the cancer has to inactivate the second allele. Usually it's a loss of that allele through loss of heterozygosity or a second mutation. So that is what Al Knudsen proposed years back as a two-hit theory, and this is also true not only for retinoblastoma but almost for any tumor suppressor gene, including BRCAs. So this is the dark cloud of pancreatic cancer. 90% undruggable alterations, P53, KRAS, no drugs for them. However, there is a small sliver of KRAS wild type, and what they choose alternatively is the fuel for their growth and insatiable drive to proliferate is a HER2, for which we have trastuzumab and multiple kinase inhibitors, BRAF, EGFR. These are uncommon situations, very rare, but if you look for them, you'll find. About 17%, if you think about this, this is almost every 7th patient you see in your clinic with pancreatic cancer will carry any of these mutations in BRCA2, 1, PALB2, ATM, RAD51. These are genes that are involved in fixing DNA breaks. And because there is another subset which doesn't carry, we don't know all the genes that are involved in homologous recombination or maintenance of genome. Another gene that has recently been nominated for that function is called RPA1. We don't test for it, but it's there. And this small minority of cases also are genomically unstable. And for that reason, if you push them overboard with drugs that directly hit the DNA, such as platinum, cross-linking agents, or mitomycin C, or radiation, or PARP inhibitor, which is the alternative pathway for DNA repair in the absence of homologous recombination. These tumors are really, really sensitive, and I'll show you in a few examples how well that may work. There is a minute proportion of these tumors that are showing a Lynch-like phenotype. They either most commonly epigenetically silence MLH1 or other mismatch repair pathway genes. And for that reason, they acquire tons of new mutations. So as they do it, they become very, very immunogenic. And for that reason, we are looking for these candidates to put them on immunotherapy trials. What was overlooked and now is really an area of very acute research interest, but Wnt pathway is deregulated in about close to a third of pancreatic cancer, even in metastatic disease. This mutation, RNF43, is a ubiquitin ligase gene, has been initially identified in IPMN, which is intraductal papillary mucinous neoplasm. Usually it presents with small to large cysts with papillary growth inside of these cysts. Oftentimes these tumors malignicize and become real pancreatic cancers. They will still carry this mutation. And the reason why it is important is that these tumors, once they deactivate RNF43, it accelerates Wnt pathway signaling dramatically, and that creates a dependency. So when you block this pathway, these tumors are very, very sensitive to it. So there are drugs currently in clinical development. Porcupine inhibitor, small molecule taken by mouth, that blocks secretion of Wnt ligand, and there are scavengers of Wnt, ipafricept and ventictumab. Again, these are now in phase 1 clinical trials. About 10% of pancreatic cancers carry MYC amplification, increased copy numbers of this ominous MYC gene, and that creates transcriptional dependency. They are very much dependent on accelerated transcription. If you block transcription with drugs like Minilite or bromidamine inhibitors, again, clinical trials, these tumors are very sensitive. This is just an illustration of the 2 trials we have here at Fox Chase. Ipafricept is a scavenger of Wnt ligands, and ventictumab, which is an antibody, it binds to the ligand binding domain of Frizzled and essentially blocks the signaling. This is the data that my colleague who spoke to you just less than months ago, Ifrat Dotan, she presented this at ESMO in October, And this is the 2 trials that she's been running here at Fox Chase, ipafricept and ventictumab. The green bars are the patients who did have significant response. This is by RECIST criteria. This is change in tumor size, and the bottom is the change in CA19-9 level. So it's very easily tolerated drug. The only toxicity of the drugs, both of ipafricept and ventictumab, is osteoporosis. This is the length of time that patients stayed on the trial. This particular patient I'm privileged to take care of is now on the trial for the 2nd year with amazing response, with no evidence of disease. He allowed me to put his picture because he is also a doctor. And this is what he went through. He was diagnosed now 3 years ago in October of 2013. Went on a clinical trial at Jefferson where he was given FOLFIRINOX with radiation and a vaccine, which a vaccine apparently was discontinued because it showed no promise. He had surgery then. Initially, tumor was unresectable. And then shortly after the resection, and he developed a recurrence, which was picked up by CA19-9 and now metastatic sites in multiple locations. He underwent repeat biopsy. We found APC pathogenic mutation, which is a component of beta-catenin signaling downstream of Wnt and frizzled. And he entered this clinical trial. This is slightly outdated now. We are in November. He's still doing well. Normal range CA19-9. He gets treated only once a month to replenish the levels of ipafricept in his bloodstream, and gets a small dose of gemcitabine once a month. He's doing well. Now we're going to switch gears a little bit and talk about the importance of detecting genomic instability in pancreatic cancer. These are the key features. I want you to look at each circle and tell me what it is. But I just put aside two contrasting manifestations of genomic alterations in pancreatic cancer. On the left-hand side is what we call genome-stable pancreatic cancers. And they have some losses and rearrangements which are depicted by these arches going between the chromosomes. So each circle is the entire human genome. The lines that connects different portions of the circle are the translocations that will create new fusion events. So you can see the genome-stable cancers have very few deletions or inversions, rearrangements inside of the genome. But this is nothing in comparison to these guys, where you have massive rearrangements, events that are so catastrophic that you would think nothing can survive it. And yet, these tumors thrive. They undergo, oftentimes, a condition called chromatripsis, when the entire chromosome breaks to small fragments and realigns itself. It creates monster genes. Knowing that helps to identify the vulnerability, because they already have gone through the stress of assembling their genomes and making it work. But if you add a little bit more DNA damage to these already perturbed cancer genomes, you will make them suffer more. And this is in the same paper in Nature by Waddell et al. From Andrew Bianchi's group, basically showing that this is sort of the measure on the y-axis how much unstable these cancer genomes are, called the BRCA score. And you can see that all of the responders, either patients or their avatar models that they grew in mice, they all have a very high score on the BRCA signature, and they usually respond very well to DNA damaging chemotherapy. They show this example, and I'll show a couple of my examples, where this patient in particular with a highly unstable genome, a lot of rearrangements and breakages, losses and gains of chromosome, was treated with surgery, gemcitabine, and had a recurrence, started on platinum therapy here, boom, complete response, alive 35 months after 3 years. We just recently assembled all the genomes we had in our avatar bank. And you can see that there is a very wide distribution on this BRCA score. So the lowest, the most stable, the highest are the most unstable. So there is probably about a fifth or 1/6 of the cases that have features of genomic instability. And what is interesting, in those who are which are stable, there are BRCA mutants, ATM mutants, RAD51 mutants, but what is important, the wild type allele was maintained for whatever reason, suggesting that if you see a mutation, you really have to ask yourself a question: is it the biallelic loss, or if there is any wild type functioning gene is present? And if it is, it doesn't matter. So here is an example. This is a 67-year-old woman. Now she's probably close to 70. She came to me 3 years ago when her son died 3 months before she was diagnosed with off-pancreatic metastatic pancreatic cancer at the age of 39. Immediately rang the bell that this is potentially genetic causality for her cancer. We tested her tumor. It was BRCA positive with this deletion in codon 5722. It's a large gene, so you have a lot of nucleotides and amino acids in this gene. And this is what we saw in the CAT scan. She had essentially borderline resectable, and if you were to resect, you would have to sacrifice all proximal portal vein. This is splenic vein. This is SMV. And here, this is the tumor kissing it and wrapping around this major vein. We decided it's not a good idea to put her through surgery up front. She was treated with radiation and grueling 6 months of FOLFIRINOX chemotherapy with a lot of complications, but she pulled through. At the time when she eventually went to surgery, this is her pre-operative CAT scan. Essentially, there is no visible tumor. You can see SMV, splenic vein, portal vein, completely patent. There is no detectable tumor. And she had complete pathologic response at surgery, and the remnant of the scar tissue was taken out. There was nothing left behind, and she's well and alive. This is another case where a patient presented with metastatic disease, this big tumor in the head of pancreas. You see a stent in the common bile duct because she developed obstructive jaundice. She was adopted as a child, so we had no family history whatsoever. She had 2 visible metastases here and a couple of more in other sections of the CAT scan. I asked my colleague Jeffrey Toker, and this is where the combination of services is so critical, because I cannot take care of pancreatic cancer by myself. I need help from interventional radiology, from gastroenterology, from surgery, from radiation oncology, from palliative care and pain management. These are complicated patients. So I called Jeff. He took the patient next day to the endoscopy suite using more advanced needles, which allow you to collect chunks of tissue. He was able to procure, without complications, enough material from this mass so that we could genotype it. We found BRCA mutation. Again, no family history. She was started on FOLFIRINOX and had almost complete response. Now she's on elaborate maintenance, traveling to Florida on a joy trip. This is how Jeff did the biopsy. You can see his needle going through the stomach wall to this mass in the head of pancreas. This is another case which I like to present because it shows the potency of genetic testing. This is a patient who had 2 sisters who died of, one died of breast cancer, the other had melanoma and breast cancer. He himself had prostate cancer 6 years prior to being diagnosed with pancreatic cancer in 2010. He went to Jefferson, had surgery with Charlie Yeo, positive margin, came to me with need for radiation and gemcitabine, finished. Soon after, had a recurrence in the liver. We put him on FOLFOX. At this time, we went after his family history. We did a buccal swab, found BRCA mutation in his germline, and assuming that this is something that is potentially related to his personal history and family history of cancers, we treated him with platinum chemo regimen. After 6 months, he went to complete remission, and he remains in complete remission now in 2016 with no evidence of disease, so essentially cured with just chemotherapy alone. This would not be possible if it wasn't for this BRCA mutation. these are the list of clinical trials, some of which are open here at Fox and across the country. People are really trying to hone in on this a particular subset of pancreatic cancer patients where we see a promise. And obviously, the many drug companies see an opportunity to advance their medications. So a lot of PARP inhibitors, as you can see, olaparib is across the board, rucaparib, veliparib, and a couple of more other PARP inhibitors. They're all rushing to the finish line, trying to show that there is a benefit in genomically unstable HR-deficient pancreatic cancers. This is still area of research, but my lab published, it's now online in the Clinical Cancer Research Journal. We did this screen of drugs, taking patients' tumors, growing them in petri dishes and in mice, and screening for drugs that are the most efficacious. What was interesting, this drug triplet was probably the best drug that we've ever seen. And in fact, if you put it in mice, and it causes remissions in some cancers, but not all of them. The reason it is so effective is that when we genetically screen these tumors, this is the measurement of absolute size of the tumor in a mouse. These all three carried MYC amplification. So therefore, the ones that are MYC amplified and transcriptionally dependent will be very sensitive to this antagonist of transcription, which is triplet. So here's our clinical team. We are 6-7 medical oncologists, all involved in thinking about pancreatic cancer and other GI malignancies on a daily basis. Crystal Denlinger is the chief of GI medical oncology. Efrat Dotan and myself, we're all involved in either translational, basic, or clinical research. So we're here to, this is one of our regular powwows where we put our heads together to think what is the next trial, what are the strategies. And here at Fox Chase, we have a wide collection of opportunity, a wide menu of clinical trials. One inhibitor, Wnt pathway antagonist. There is a biomarker clinical trial where we try to genotype determine put patients on appropriate type of chemotherapy. IGFR1 antibody for those who are, for those tumors that have high dependency on IGFR1. BRCA mutated cancers, we usually started on a platinum-containing regimen, then switch to olaparib maintenance. Michael Hall leads this effort. There's a lot of interest in understanding the social, economic, and behavioral impact of pancreatic cancer on patients and their caregivers. Caroline Fang here at Fox Chase is trying to determine whether walking and physical activity improves the outcomes. And in fact, physical activity improves the immune system, and there's a strong biological basis for this. So she has a walking study where we ask patients to ambulate, to prevent clots, prevent muscle wasting. Surgeons are very active. John Hoffman and Sanjay Reddy are two lead surgeons here at Fox Chase. They study the role of peritoneal washings in reducing the peritoneal recurrence after surgery. Nestor Isnaiola leads two studies in which he tests gemcitabine Abraxane versus FOLFIRINOX as part of the large national study. And Joshua Meyer, who is our expert radiation oncologist and specializing in GI malignancies and pancreatic cancer, is studying margin status and need for radiation in these patients. So this is our group. We are very passionate about pancreatic cancer, all of us. I'm now going to open the panel, a podium for questions, and if you have anything else to add or share your experience, please do so.